Hi, I'm Dr. David Todd. I'm coming to you from Western University of Health Sciences, specifically the College of Optometry in Pomona, California. We're here to give you a webinar tonight that has been made possible by an unrestricted educational grant from NovaVision Incorporated. NovaVision and Western College of Optometry both have a keen interest in the field of neurologic vision loss and rehabilitation of vision. Now, before I start, I obviously want to go right to my financial disclosures. That is important. I don't want any mistakes made. As I said, my full-time position currently is on the faculty of Western University College of Optometry in Pomona. I have worked and do work as a scientific consultant to NovaVision Incorporated in Boca Raton, Florida, largely because of my background in vision restoration and vision rehabilitation. I work on a consultative basis with a company called Health Research Sciences. I've acted as their chief medical officer. I've done some clinical consulting to ECR Volt, which is a paperless office solution. And lastly, my research partner, Frank Spores, and myself do have an informal partnership with Hogstrite USA for some visual field research. So, to start out with, let's talk about the subject today. What are we talking about? We're talking about neurologic vision loss. What is that? What is neurologic vision loss? Well, technically defined, it is a loss of visual function arising from damage to the visual pathway posterior to the lamina cribosa. And it's characterized by a number of different traits. I mean, we can have different varieties of neurologic vision loss. You can have your sectoral loss, like quadrants or hemianopias. There's also diffuse small scotomas like a central blind spot you can get from certain types of optic nerve damage and other scotomas. You can get a general reduction in visual sensitivity. I've seen that in toxicity or optic nerve injury. And you can also rarely get an inability to recognize objects or things of certain character, like colors or certain types of objects. Those disorders are called agnosias. They're rare, but you do see them. Now, I'm sure most of you are pretty familiar with the chart showing us the different types of central field loss, which goes all the way from, absolute or at least relative monocular loss as a result of optic nerve injury, and it goes back to the chiasm. Although it's not listed here, we know that there are those bilateral or bitemporal defects. As you get more and more posterior, some people say that the defects get more and more homonymous. Some people differ with that, but as a rule, I think it's safe. We've got quadrants that can happen in the temporal lobe or the parietal lobe, and again, hemianopias as you get further back in the brain. They get a little weird when you have injuries around the geniculate body, but in general, they get very homonymous as you go back. But vision loss isn't the only thing. In fact, it really only happens somewhere between 15 and 25% of the time. What you will see much more often in patients who present to you with this problem are physical problems. And we've got a list of those, obviously, here. You've got problems like paresis, which, if you've seen it, it's a relative weakness or loss of neurologic control in part of the body. It usually respects the midline, right paresis, left paresis. More severely, you can have paralysis, complete loss of neurologic control on part or all of the body, everything from quadriplegia to hemiplegia, things like those. When you've got a more profound motor and sensory loss below the middle of the body, then you start to deal with a lot of truncal instability. That's when folks come in a wheelchair or some other type of transportation with a harness on. And that's because they can't sit up straight. They've lost the ability to control their posture. A lot of brain injury patients will suffer from a tremor, an attention tremor. That's also present in a lot of neurologic disease. I think we've all seen it in Parkinson's. Ataxia is a problem that's fairly common, but very few of us know what that means. What that means, it's very associated with cerebellar injuries, but it can happen for a number of reasons. It's an inability to perform fine motor control when you're reaching for a small object, the inability to control yourself in a fine way. Neuralgias can occur. I mean, that's not just for people after herpes, but I've actually encountered a number of patients with, let's say, a hemiparesis, where you touch them and it can be quite painful to them. Lastly, this is an important fact to know, and that is that every brain injury sufferer, everyone who suffers from a brain injury, whether it's traumatic or vascular, has a dramatically higher chance of suffering seizures for the rest of their life. And it can happen numbers of years after the original insult. So all of these are general physical findings that you'll encounter in the folks we're talking about. But again, for those of us who are mostly concerned with the neck up, there are still some other ocular signs of brain injury besides just loss of vision. Obviously, we all have encountered folks with cranial nerve palsies, and I think we've seen the total thirds, things like that.
This is Chaz. He has a complete third nerve palsy, as you can see there, with pupil mydriasis, but a normal eye in the right. If we directly illuminate it, we see about a 2+, slightly sluggish, direct reaction. In his paralytic eye, we see virtually no reaction. The way we know he's got no APD, open wide Chaz, is if we direct illuminate here and swing over. There's no release. He's refixating. Okay, so remember that this young guy's got a complete third as a result of trauma. So already, if we look, go ahead, open your eyes as wide as you can, especially your bad eye. There we go. See, he's got some levator function already. Now here's what we want to look at. Do me a favor, Chaz. Look way to your left, like that, and now look way to your right. And what we can see, way to the left.
Less commonly, you might encounter a sixth nerve palsy or INO, intranuclear ophthalmoplegia.
Essentially, we're looking at an isolated sixth nerve palsy. Now watch this pencil wherever it goes. Don't move your head. Complete abduction the left, adduction the right. We follow, we pass the midline, and the OD stops short while the OS follows. Again, good conjugate gaze, and a complete abduction deficit OD. Now, okay, what we can also notice is...
And sometimes following a traumatic injury to the side of the face or the head, even viral injury, you can experience aberrant regeneration in jaw winking syndrome.
Keep going. Good man. Good man.
Now, one big thing, there are actually 2 points after brain injury that I think most optometrists really need to remember. One is that no matter how young the patient is, once they've experienced brain injury, certainly with traumatic, but it still can happen with acquired vascular injury, and that is the relative loss or complete loss of accommodation following the injury. When these folks come in, they'll frequently go to other eye care providers, have the health of their eye checked out and be relatively healthy in that respect, and be given a pair of glasses for distance. They'll go to school, they'll go to work, and they can't see up close. Nobody can figure out what it is. Well, guess what? It's simply that they've lost their accommodative sufficiency. They've lost their accommodative reserve. Those folks need help. They're going to need ads or readers from then on. The second very prevalent after effect in our world after brain injury has to do with convergence. I would say that easily 80 to 90% of all of my brain injury sufferers will suffer from dramatic convergence insufficiency after their injury. And that's problematic. You've got to look at that as well, because otherwise a lot of these folks in the process of trying to assimilate back into life, into work, into reading, into school, is that they can't converge, and it's unpleasant to try to work up close, and they avoid it. And then they just get warehoused. They don't move forward in life. Now, there are some other things that are more noticeable, more severe. I know for me, non-combinant strabismic deviations can be very frustrating, but you'll get those, especially when the orbits have been damaged. And another problem that we see very frequently after a more diffuse brain injury is nystagmus. Certainly, depending on the locus or the type of injury, you can get vertical nystagmus, certainly in the midbrain with the 6th and 7th and 8th nuclei in the middle there, you can get rotary nystagmus and gaze-evoked nystagmus. It's fair game. You can see any of those.
Look straight ahead and just follow this thing wherever it goes. Don't move your head, just your eyes. No double vision, right?
Not there.
Anything there?
Little.
Okay.
Yeah.
Okay, straight ahead, you see it?
Yep.
Try to follow it all the way in. Just go double then?
Yep. Right there.